Okay, let's talk about neonatal jaundice. If you've spent any time in a newborn nursery, you know it's something we see every single day. But behind that common yellow hue, there's always a critical question. Is this a benign, normal thing, or is it a neurological emergency in the making? So over the next few minutes, we're going to walk through the clinical framework to help you answer that exact question every single time.
So, just how common are we talking about? Well, about 60% of full-term babies will develop some jaundice. And for preterm infants, that number jumps to a staggering 80%. This isn't some rare finding. It's a routine part of neonatal care, which makes our ability to sort it out quickly and effectively that much more important. And right, because it's so common, we face this question constantly. Is this just a harmless temporary phase that'll go away on its own? Or is it the first warning sign of something that could lead to kernicterus and permanent brain injury? You know, the stakes are incredibly high. Getting this distinction right isn't just part of the job, it's our primary responsibility. So here's our game plan for this explainer. We're going to start with the basics, then get into the really crucial part, telling the difference between physiologic and pathologic causes. From there, we'll build a differential, run through the workup, and finally, cover how we treat it. It's a structured approach that mirrors how you'd think through a case in real time. All right, let's start at square one, just to make sure we're all on the same page. What exactly is neonatal jaundice? So the technical term is hyperbilirubinemia, but it's really just an excess of bilirubin floating around in the blood. And in most newborns, this is totally predictable. It happens for two main reasons. One, they're breaking down a lot of red blood cells after birth, and two, their liver is still pretty immature and can't clear all that resulting bilirubin fast enough. For the most part, it's a normal and usually harmless part of a baby's transition to life outside the womb. And that brings us to what is probably the single most important decision point. Everything that comes next hinges on our ability to figure out if we're dealing with that normal physiologic process or something much more serious. So how do we make that call? This table, right here, gives us our core rules of thumb. Physiologic jaundice, the normal kind, follows a predictable script. It shows up after the first 24 hours of life, it usually peaks below 15, and it's gone by about 2 weeks. Pathological jaundice, on the other hand, breaks all those rules. But of all these points, the one you absolutely have to burn into your memory is the first one, onset. The timing tells you almost everything you need to know right off the bat. And here's the bottom line, the one rule to live by. If you see jaundice in a baby that's less than 24 hours old, your alarm bells need to be ringing loudly. This is a non-negotiable red flag. You have to assume there is something serious going on until you have done a full workup that proves it's safe, period. Okay, so the red flag is up. We see jaundice in that first 24 hours. Now our job totally shifts from just spotting the problem to investigating it. We need to start building a differential diagnosis to figure out the why behind that high bilirubin level. You know, a good way to organize our thinking is to group the causes into 4 main buckets. First, are we just making way too much bilirubin, usually from red blood cells breaking down? Second, is the liver having a hard time grabbing the bilirubin from the blood? Third, is the machinery inside the liver that processes bilirubin broken? And finally, is the gut reabsorbing bilirubin that it should be getting rid of? Framing it this way really helps structure your workup. And this timeline, this is basically our clinical cheat sheet. If it's day 1, your mind should immediately go to hemolysis, things like ABO or RH incompatibility, and you have to consider sepsis. On days 2 and 3, the list gets a bit longer, including things like G6PD deficiency. And after 72 hours, our focus shifts again to stuff like breast milk jaundice or even hypothyroidism. The clock is a really powerful diagnostic tool here. Now, this is a super common point of confusion, so let's clear it up. Breastfeeding jaundice happens early, in that first week. It's basically a starvation jaundice. The baby isn't getting enough milk, gets a little dehydrated, and can't clear the bilirubin. The fix? Fix the feeding. Breast milk jaundice, on the other hand, happens later, peaking around 2 to 3 weeks. It's a totally benign thing where some substance in the milk itself seems to slow down how the baby processes bilirubin. 2 very different issues with very similar names. All right, so we've got our differential diagnosis based on the timing. Now let's talk about how we confirm our suspicions with the actual clinical workup, starting with what we can see on exam and then moving to the lab tests. Before we even draw blood, we have a pretty useful tool we can use right at the bedside. It's called Kramer's rule, and it's based on a simple observation. Jaundice tends to progress from head to toe. Now, it's not a replacement for a lab value, let's be clear, but it gives you a quick and dirty estimate of how high that bilirubin might be.
Yeah, the progression is pretty predictable. If the jaundice is just on the face, we're thinking the bilirubin is maybe around 4 to 6. Once it gets down to the lower trunk, we're probably looking at 8 to 12. But the real clinical pearl here is zone 5. If you see yellow on the palms and soles, that's your cue to act fast. That suggests a bilirubin level over 15 and means you need a serum level, like right now. This is our standard opening panel of tests. Step 1 is easy. What's the number? Get a total and a direct bilirubin. Steps 2 through 6 are all about finding the why, and specifically hunting for hemolysis. We check blood types to look for a mismatch, we check hemoglobin for anemia, and look at the blood smear for signs of destroyed red cells. The reticulocyte count tells us if the bone marrow is trying to compensate. And finally, the direct Coombs test is our smoking gun. It directly detects antibodies stuck to the red cells. This panel just systematically walks us through our biggest concern, hemolysis. Okay, so we've identified that there's a problem, and we have an idea of what's causing it. Now what are we actually going to do about it? Let's talk treatment. For the vast majority of cases, the answer is phototherapy. It's a really elegant and non-invasive treatment. We use a specific wavelength of blue-green light that penetrates the skin and literally changes the structure of the bilirubin molecule. It's like we're creating a workaround for the baby's immature liver. So how on earth does light fix a metabolic problem? Well, it acts like a catalyst. The most important thing it does is something called structural isomerization, which converts bilirubin into a water-soluble form called lumirubin. And the genius of this is that lumirubin can be excreted directly into the bile and urine, completely bypassing the need for the liver to process it. We're essentially creating a backdoor exit for all that extra bilirubin. Of course, no treatment is totally without side effects. The lights are warm, so we have to watch closely for dehydration from water loss. It can also cause looser stools, which is pretty common. And a really key thing to remember is that you should not use it if there's high conjugated or direct bilirubin, because that can cause something called bronze baby syndrome. So always know your direct bilirubin level before you turn on those lights. Now, what if intensive phototherapy isn't enough and the bilirubin is climbing to neurotoxic levels? Well, then we have to pull out the last resort. A double volume exchange transfusion. This is an emergency procedure. We are physically removing the baby's blood, which is full of bilirubin and antibodies, and replacing it with donor blood. The goal is to crash that bilirubin level as fast as possible to prevent irreversible brain damage. And that really brings us to our final thought here. We have great treatments, but the ultimate goal should always be prevention. When you know just how devastating severe hyperbilirubinemia can be, it really pushes us to ask some bigger questions. How can our systems get better at proactively screening for underlying risks like G6PD deficiency before a baby ever shows up in a full-blown crisis? That's the real challenge that still lies ahead.